A very good evening to all the participants who have joined for the National Meet series for the month of May, which is being hosted by AFPI Kerala chapter. So the topic that has been chosen for today is one that we encounter very commonly in our general practice: how you manage asthma exacerbation in your general practice. The session will be dealt by Dr. Jayaganesh, who is a registrar in the Department of Family Medicine at KIMSHealth, Trivandrum. And the session will be moderated by Dr. Indhu Rajeev. She's a senior consultant in critical care and family medicine at Lourdes Hospital, Kochi. She's also the past president of AFPI Kerala chapter. I hereby invite Indhu ma'am to take the sessions from here on. Over to you, ma'am.
Thank you, Dr. Vishnu. Good evening, all. So as you all know, the World Asthma Day is commemorated on May 5th. So it's a wonderful month to start with this topic. Okay, so the theme for this year this is actually organized by the GINA, Global Initiative for Asthma. And the theme is access to anti-inflammatory inhalers for everyone with asthma, still an urgent need. So Jayaganesh will be presenting on the asthma exacerbation, because GINA, as such, asthma is a very large topic. It will cover for adults, adolescents, child, and also children less than 5 years. So we don't have time for all that. But we need to know more about asthma, how to deal with it in primary care when you get an asthma exacerbation. So it's a wonderful topic, and I request Dr. Jayaganesh to start off with the topic.
Thank you, ma'am.
And Dr. Jayaganesh, I would like to introduce you. He is a specialist family physician from KIMS Hospital, Varkala. He's also a SPICE Route 360 FM coordinator also. Over to you, Dr. Jayaganesh. Best wishes.
Thank you, ma'am. Thank you for the introduction. Thank you, Dr. Vishnu. And am I audible, ma'am?
Yes.
Yeah, you are audible.
Okay. So I think we can start with our session. So is the slides, are the slides visible?
Yeah. Proceed.
Yes.
So coming to the topic straight away, I have taken the slides from the GINA guidelines because I think that's the only best option to crack the guidelines, because even now most of the consultants and will be feeling nausea while we open the guidelines, and after reading 2 to 3 pages we'll start sleepy. But I believe that the guidelines has been put on in such a way that it is easily understandable in small in simple words, and for the same concept, for one concept they have put on flowcharts. In the next page they have put on many tables, and later after that they have made a huge description on that, and they have made a good attempt in to explain all these concepts. So I think it will be the wise decision to take the tables and flowcharts directly from the GINA, so that after the session for the PGs, while going through the guidelines, you feel more familiar. You won't feel that kind of nausea while looking onto that flowcharts. So our learning objectives will be more focused on the the exacerbation of asthma, the acute exacerbation, as well as the personalized management steps, and few points on how we manage these patients in our clinics and their follow-up, and few words about their referral also. So here, acute exacerbation management can be classified as into 2 sessions. First one for adolescents, adults, adolescents, and more than or equal to 6 years of age children. And second, they have put on a separate thing on the children less than or equal to 5 years. Few changes have been brought in this new guidelines on the 2026 compared to the 25. And later on, we will be dealing with personalized management steps. And in there, they have put on separate three um, three sections on adult and adolescents more than 12 years, more than equal to 12 years as first one, and separate one for children in between 6 to 11 years, and children less than or equal to 5 years as the third part. And we also will be looking at the non-pharmacological interventions and few points on referral for expert advice. So why the asthma exacerbation matter? Because we'll be thinking, oh, it's just an asthma. If a patient comes to our OP and he's having some wheeze and he's telling that I'm having asthma, then you'll be relieved. Oh, thank God, it's simply an asthma. We no need to look for any other DDs like any pneumonia or bronchiectasis or the nightmare COPD. So, but actually, it does matter because around 300 million people are affected globally. Around 1,000 asthma deaths are happening every day worldwide. And the good part is that most of the deaths are preventable. And even each asthma exacerbation increase the morbidity, the hospitalization risk, and also the more importantly, the oral corticosteroid exposure. And definition of asthma, I won't be going to that because it's a huge part. So what's the new things that they have brought new structured flowcharts, and they have stressed upon the oxygen threshold, like give O2 only if there is oxygen saturation dipping less than below 92%. And they have emphasized on targeting the SpO2 between 92 95%. And they are more conservative on SABA dosing, that is salbutamol dosing. And ICS formoterol can be used in mild exacerbation. That's a new change that we'll be looking on. And a strong focus on oral corticosteroid stewardship. So before that, before going into the management, we have to look on the risk factors for the severe or fatal exacerbation. While a patient present to us, we have to take a good history. And in that, we have to assess all these risk factors. The high risk factors are, is there any previous ICU admission or intubation for asthma? That we have to ask. Is there any recent emergency department visit or hospitalization? That is it, especially in the past, within the 12 months. Is there any exacerbation, severe exacerbation in last year? Is there any food allergy confirmed with confirmed asthma? Are there any psychosocial issues or major socio-economic problems? This is our highlight. Being a family medicine specialist, we have to emphasize on this too. Usually other specialties will be missing this point. And we have to look on the modified risk factors, like are there any overuse of SABA, whether there is a poor adherence to inhaled corticosteroid therapy, the inhaler technique, is it correct or not? We have to look for the obesity, smoking, allergen exposure, and also if there is a low FE1 ratio, FE1%, and high bronchodilator responsiveness, we have to look. And few points about the inflammatory and biomarker risk. That is raised blood eosinophils we can check, and we can look for the fractional exhale nitric oxide, that is FeNO. If it is high, then these are all high risk factors. And also type 2 inflammatory markers like sputum eosinophils and the serum IgE levels, and inadequate inhaled corticosteroid prescription or their dose, and lack of written asthma action plan. These are the risk factors that we have to assess while a patient comes in front of us. And severity assessment is the next point, from where we have to classify, we have to manage the patient. And the mild will be like the patient comes in front of us and he's able to, or she's able to talk in sentences like, doctor, I am having asthma, I'm having breathlessness since so and so days. The patient is able to complete the sentence. And while examining, the patient is able to sit, and he's not agitated. But the respiratory rate can be increased, but the accessory muscles are not being used. While examining the vitals, the pulse rate is around 100 to 120 beats per minute. And there is a fair SpO2, like more than 90%. And the predicted or the best peak expiratory flow is more than 50%. Then we can classify the patient into a mild. So what about the severe? the patient is able to talk in words alone. Like, doctor, I am having a breathlessness since past 2 days. Like that, the sentence will be broken, and the patient prefers to sit hunched forward, like leaning forward. The patient will be agitated. Like we keep on asking the patient more and more history. The patient feel like irritated, and he gets agitated while there is an bystander annoying, and the respiratory rate will be more than 30. And here the accessory muscles will be used. Pulse rate will be high, like more than 120. And here the SpO2, oxygen saturation, will be less than 90%. And the peak expiratory flow rate will be less than or equal to 50%. And what about the life-threatening? How can we identify the life-threatening? And these are the can be the red flags. The red flags can be this life-threatening asthma. Like if the patient is drowsy or confused, if the patient is unable to speak, is quiet and or exhausted, there is paradoxical breathing. And while you auscultate, there is silent chest. We'll often miss this. Like we'll think, oh, the chest is clear, the chest is silent, he's okay. But it is actually a nightmare, it's an alarming sign. And there is bradycardia, hypotension, and or cyanosis while you examine the patient. And there is saturation less than 90%, even with oxygen O2. And peak expiratory flow rate is not measurable. This is how we classify the patient into mild, severe, and life-threatening. So there is a PRAM score, that is Pediatric Respiratory Assessment Measure, which can be used for children from 2 to 17 years. And here we will be looking at the same thing, like first oxygen saturation, second one the suprasternal retraction, third is scalene muscle contraction, that is the accessory muscle, and fourth is air entry, and fifth is wheezing. From this, we can put the score the patient. The severity can be scored. Like if there is oxygen saturation more than or equal to 95, we can put 0. If it is less than 92, it is 2. And so there is suprasternal retraction, there is score of 2. If there is scalene muscle contraction, there is 2 score. And regarding the air entry, there is a decreased air entry at the base, and it is 1. At the base and apex, air entry is less, it is 2. And if there is no air entry, it is 3. And regarding the wheeze, if it is expiratory only, it is 1. If there is inspiratory, with or without expiratory, it is 2. And it is audible without a stat or in silent chest, it is 3. Like that, we can score. And from that score, if it is 0 to 3, it is a mild episode. If it is 4 to 7, it is a moderate episode. If it is 8 to 12, it is a severe episode. This can be used in children from age 2 to 17 years. And initial assessment in primary care or an emergency department will be the same that we have discussed, like ABC. We can go with ABC, airway, breathing, circulation, and we can triage the severity based on whether it is a worst thing, whether it is a life-threatening sign, either if there is any red flags, then we can refer the patient by giving some inhaled SABA or like that. And next is vitals we have to check, and their mental status we will be checking. Lung function test before and after bronchodilator, that can be done only if it is a tertiary care setting or at least a secondary care setting, and there is available facilities and the patient is not on a severe or life-threatening asthma. Only in mild or moderate we are able to do that. And differentials, we have to exclude a many differentials, especially anaphylaxis. Anaphylaxis can be a common cause in this shortness of breath, or that is breathlessness, and rule out the cardiac causes and also COPD elderly patient. And while taking the history, triggers we can ask, is there any allergen exposure? Have you taken any drugs before the event? Have you been anywhere else? Is there any cold exposure? Like that, you can ask. And risk factors that we have discussed before, medications also we have to ask, and adherence, whether the patient is compliant with the medication, whether he is taking the medication properly, has to be asked. So in coming to the primary care management of adults, adolescents, and more than or equal to 6 years. This is one of the change being made in the 2026 guidelines. Like earlier, it was like before, that is more than 12 years was one thing, and less than 12 years was another, less than 5 years was another. Now it has become a complete one for more than or equal to 6 years, including adolescents and adults. So here the patient is appearing into the primary care. and we are assessing the patient, like are the current symptoms due to asthma, that we have to ask, and consider known asthma causes like pneumothorax, anaphylaxis, any inducible laryngeal obstruction. Especially, we have to ask foreign body in children. But more than 6 years, the foreign body is less likely. But less than or equal to 5 years of children, if a child is coming with, to your clinic with a wheezing, a unilateral wheezing, especially with fast breathing, with a cough or any other discomfort, always rule out any foreign body in the airway, or rule out the pneumonia, acute cardiac failure in, or especially in old patients, pulmonary embolism. Also, you have to ask. So, what treatment has been already been given? Any red flag signs we can ask. From that, we have earlier seen the mild presentation, moderate presentation, and severe presentation. So, if it is mild presentation, then we can start with the salbutamol, 4 puffs, and with a spacer. That spacer has to be stressed. So now in the new guideline, ICS with formoterol has been introduced. Either the salbutamol can be used with the spacer, or ICS formoterol can be used. That can be given as 2 puffs. This is the new change being made in the guideline. That is only in the mild presentation. And if it is a mild presentation, we can wait for at least 30 to 60 minutes and reassess the patient. And if needed, we can repeat the dosage. We can repeat the dosage for at least 3 times or 4 times we can repeat. So here we can review the response at 1 hour or earlier. And if there is improvement, then we can plan for discharge. So what will we assess during the reassessment? The same thing, assess oxygen saturation, respiratory rate, accessory muscle use, air entry we can check, and we can score the PRAM score if if it is a child less than 11 years. And if needed, additional bronchodilator can be given. And if it is moderate presentation, salbutamol can be given, again 4 to 6 puffs with spacer up to 3 times. Here we will be repeating it 20 to 30 minutes. Every 20 to 30 minutes we can give, and that can be given up to 3 times, which means it becomes 1 hour. And if there is ipratropium bromide is available, that is a short-acting muscarinic antagonist. If it is available, we can give, and that is 4 puffs we can give along with salbutamol. That is 3 times with salbutamol we can give. And here we can start the oral corticosteroids. Oral corticosteroids can be started. And again, after 1 hour, reassess the patient and we'll check. If there is worsening, we have to arrange for transfer. And here, if it is severe or life-threatening, and we have to arrange transfer immediately to an acute care facility. And before that transfer, we have to do some few points has to be done, like give salbutamol 6 to 10 puffs along with spacer, and it can be repeated again 20 to 30 minutes before the transportation arrives. And if ipratropium bromide is available, again the same thing can be given. And O2 we have to give to maintain the target oxygen at 90 to 95%, and give IV corticosteroids. Here, if it is severe, we can give, or if it is acutely life-threatening, we can give IV steroids, and plans for transfer the patient. And one thing we are stressing here is the usage of spacer and ipratropium along with oral corticosteroids if it is moderate, or if it is severe, systemic corticosteroids. Here, what we used to do in our OPD or in our clinic day-to-day practice is that even if the patient is having a mild, we will be starting with an oral corticosteroids, or we'll giving an IV steroid, and we will give an O2. And if it is a moderate, again the same thing. We'll be giving a nebulization. Actually, there is an option for nebulization, but the dosage has been given as 2.5 mg. But in our setting, we will be giving like levosalbutamol. That duoling combination will be used. And duoling, there is both levosalbutamol 1.25 microgram, along with that ipratropium bromide 500 microgram. That is actually a few slight higher dose being given more than the guideline recommendation. But it's okay if the nebulization it is preferable. Like an inhalation, nebulization is equivalent to an meter dose inhaler with a spacer. So we can prefer both. And after reassessment, even if it is mild or moderate, after reassessment, if it is improving, we can assess for discharge. So what are the criteria for discharge? Discharge, if it is oxygen saturation maintaining more than or equal to 92%, and the patient has come to the mild criteria and has improved, and the peak expiratory flow rate is improving more than 70%, and there is no requirement for further short-acting beta agonist usage, and there is adequate resource at home. That is the whole how the patient's house is near to the clinic. If something happens at night, they are able to bring the child or bring the patient to the clinic like that. Or if there is nebulizer at the home, also we can plan for discharge. Then arrange before discharge. We have to document the diagnosis of asthma, and we can plan increasing the ICS, that is inhaled corticosteroids, if already on ICS, or we can start on the ICS if not already started yet. And reliever, regarding the reliever that we'll be seeing in the next slides, reliever, this again the same ICS can be used as reliever. If it is children, we have also the option of SABA. And continue oral corticosteroids if it is indicated. Train the patient as well as the bystander regarding the inhaler technique, and reinforce on adherence, and ask them for follow-up. Like if it is a child, we have to ask the child to follow up on 2 to 5 days, within 2 to 5 days. If it is adult, up to 7 days we can wait. And adequate follow-up with proper review and reassessment of medications has to be done on follow-up. So what will be in follow-up that we can check in next slide. So I have also put down the management of acute exacerbation while you are at a hospital or ED. Actually, there is only a few changes, differences being there. Like if you have the facility, then you can call for anesthesia. You can call the PICU people, and you can establish IV access. You can start on IV magnesium sulfate. That comes under the severe or life-threatening while you are at an ED or in a tertiary care hospital. And again, the same thing, mild presentation, we will be assessing whether it is mild or moderate or severe, and starting the treatment almost the same. And again, the same thing is coming. And here also we can plan for chest X-ray. We can just look for the blood gases, and we can assess the patient more frequently. And almost the same thing. While at an ED or while being at a big hospital, we can have more frequent reassessment. And after that, the same thing, planning for the discharge. And while if the patient is worsening, we can also plan for admission. There we have to refer the patient to an acute care facility, but here we can plan for admission. Like if the oxygen saturation is still less than 92 on room air, and if there is ongoing need for SABA more than every 1 to 2 hours, there is dyspnea persisting 4 to 6 hours even after receiving the systemic corticosteroids. And if it is not improving, we can plan for the admission also. So again, this stressing on the discharge plan, the criteria for discharge, the symptoms, if it is improved, there is no need for any SABA more frequently. A PEF has been improved more than 70%. Oxygen saturation has become more than 94%, and resources are adequate at home. And before discharge, optimize ICS, provide a written asthma action plan. Like that plan we can discuss. Like it's simple. Like if there is a cough, if the patient is feeling any breathlessness at home, you can take 4 puffs at home. You can wait for 20 to 30 minutes. You can repeat the puff, and up to 3 to 4 times you can wait. And if still you are having the issue, the problem, you can come to the hospital. Like that, we can put out an asthma plan. And regarding the tapering of medicines, regarding the adherence of medications, everything can be given on a written action plan. And follow-up has to be done. And coming to the less than or equal to 5 years of children, the presentation will be almost the same. But here we have to look for other DDs while presentation, like bronchiolitis, any croup, their foreign body, they are more common than asthma attacks. So the severity again the same. We can use the PRAM score here. We can assess the patient and categorize into mild, moderate, or severe or life-threatening. Here, actually, the old thing has been followed. Like there is only use of SABA in mild presentation. There, the adult patient, we have seen that SABA with spacer or ICS formitrol can be used for mild presentation of acute attack in the mild category. But here there is no change. As earlier, as the previous guideline, only SABA has to be used, but stressing more on the spacer. Or we can use a nebulizer of that is salbutamol 2.5 mg nebulizer. Actually speaking, we can use levosalbutamol. Levosalbutamol, the dose will be 1/4 to 1/2 of the salbutamol dosage. And assess for the response, we can repeat if needed after 30 to 60 minutes. If it is moderate, again the same thing. Salbutamol can be given 4 puffs with the spacer, or nebulizer we can give. Again the same, that is short-acting muscarinic antagonist. Right? Ipratropium can be given up to 4 puffs up to 3 times. Actually, I would like to put on some examples of describe this with some example. Like ipratropium, we can think of Ipravent. I'm not telling on any brands, but it's a common, just to remind easily. Ipravent, it is 20 microgram. That is a dose. That can be given up 4 puffs up to 3 times. But here in our OPDs and clinics, we'll be having the Levolin or combination of Deolin, combination of that is Levolin, that is levosalbutamol with this ipratropium bromide. That also we can use. And here, if it is moderate, we can start on oral corticosteroids. And if it is life-threatening, like the criteria we have said, we have discussed before, again the same thing. If it is anaphylaxis, give IM epinephrine. Salbutamol, we have to give like 4 to 6 puffs every 20 minutes, ipratropium. And systemic, that is IV corticosteroids, we have to give if it is severe or life-threatening. O2 we can give and monitor continuously. Again, after 1 hour, reassess with oxygen saturation, respiratory rate, PRAM scoring, everything we can use. If it is improving, again, assess for the discharge, that is plan for discharge. If it is worsening, again, we have to manage it with like severe life-threatening asthma. And before arrange, the same thing we have to plan. I'm not going to repeat all these things, the same thing we have discussed before. And here we are stressing on the follow-up of after 1 to 3 days in children less than or equal to 5 years. More frequently, by a close date, we have to ask the patient to follow up. And the reliever regarding the home management, we can discuss in the next slide. And coming to the ED or hospital management of less than or equal to 5 years of child, again, the same thing. Here, I've told you that there is a backup facility with PACU or anesthesia. We can go with IV magnesium sulfate, IV aminophylline, corticosteroids, IV. We can go with investigations like chest X-ray, CT scan, blood gas analysis, etc. And again, the same thing. So discharge planning for children, again, we have to look for FSPO2. It should be at least 94% on room air. There should not be any frequent use of SABA. PF is improving. And moreover, here we have to stress on the caregiver should understand the plan. The child won't be able to mug up everything. But the caregiver should be educated at least, or at least we should be able to convey in their own language. We should be able to demonstrate with the inhalers. We should be able to give them written action plan and what should be done with the acute attacks at home, how they should manage their attacks, and when should they bring the child, what all red flag signs they should watch on their children. That should be properly educated to the education should be given to the caregiver. And adequate resources should be there at home. And reliever can be given and not regularly. And initiation of ICS or increase in dose of ICS. And oral corticosteroids, a short course can be given. and follow-up should be booked in 1 to 3 days. And coming to the, so that's about the acute management presentation. So coming to the personalized management steps. Here, adolescents, more than or equal to 12 years, and adults. This flowchart is being given in all the new GINA guidelines. During exams also, I think it's if we draw this, we get good marks. Some marks will be given for this, I believe. So while the patient comes to you, review. Review means review the symptoms, review the exacerbations, side effects, comorbidities, lung functions, consider biomarkers, and patient and parent or caregiver satisfaction has to be ensured. That is another point that we can stress as family medicine specialist. And assess for, that is confirmation of diagnosis if necessary. And we have to always keep in mind the other DDs, differentials, and not being a narrow-minded, we have to also think in different ways. Are there any other diagnoses that we are missing or not? And symptom control and modifiable risk factors. Again, during each visit, we have to ask for risk factors. Are you doing that? Are you doing this? Are you following up? Are there any history of ICU? Are you taking the inhalation properly, like that? Comorbidities we have to assess, and mostly inhaler technique and adherence. During each visit, we have to ask the bystander to bring the inhaler with the spacer, bring all the medications, and to demonstrate it in front of us, so we can pick up the issues. That is any incorrect method, we can correct it in front of us, and we can show them, demonstrate them. So that during each visit, we have to ask them, we have to emphasize them to bring on the medications and to perform it, demonstrate it in front of you. And patient preferences and goals, like we have to address the patient's issues, like doctor, they will be saying that, doctor, I am having difficulty in carrying the huge spacer with me, so I am just using it without spacer. So that's a big issue. Spacer means it is the most effective way of delivering the medicine. So if that's an issue in adherence issue, that is making the patient use less, then we can switch on to some other, that is synchro breathe, that is automatic breathing devices, inhaler, many other devices are there. Protocabs we can do. Many other methods, many other devices can be given. So that has to be given stress. That has to be stressed upon whether the patient and the caregiver are comfortable with the current medication, with the current devices. And also treatment of modifiable risk factors we can provide, and the non-pharmacological strategies, and education and skills training and action plan. So coming to the management, that is this is the actually, I think you'll be familiar with this step. This is what being given in another form in this flowchart. So while the patient presents to you, if the patient is having daily symptoms, that is, doctor, I'm having breathing difficulty or cough every day, or if the patient is waking at night once a week or more, doctor, I'm waking up at night at least twice a week, or at least once a week, and along with that, while you assess, there is a low lung function, or there is a recent exacerbation. So either daily symptoms or at least once a week waking at night, along with low lung function, we can go with step 4. Usually 2 tracks have been given, and track 1 is referred. And what is that? Medium dose ICS formoterol, maintenance and reliever therapy, MART. That is, medium dose daily ICS formoterol has to be given. And coming to the step 3, that is, if the symptoms are present in most of the days, like doctor, I'm having daily symptoms, or waking at night once a week or more, again the same. But here, the low lung function is not present. It is like or. Either there is a daily or almost everyday symptoms, or there is at least once a week waking at night, or there is low lung function. Then it has to be treated as at step 3. like with a low dose ICS formitrol MART. And still, no, there is no such thing. It is less frequent symptoms. The symptoms are at least less than 3 to 5 days a week with a normal or mildly reduced lung function. Lung function is normal. Then it is either the step 2 or step 1. Why it is being given as two separate steps means in track 2, there are two options, but we used to follow. It is preferable to follow the track 1. That is the same thing, ICS formitrol low dose, it is used as SOS. And that same medicine is being given as another label as acute inflammatory reliever AIR. It is not a different thing. The same low ICS formitrol, if it is used as SOS, it is known as AIR. If it is used daily, it is known as MART. That is maintenance and reliever therapy. What we have to look is that the patient in this from step 3 to step 4, if the patient is taking the ICS formitrol on daily basis, if any attacks come in between, SOS can be used. It can be used SOS as needed. The same inhaler can be used. There is no need for a different reliever. So that is being given in this step. The same thing we have discussed. If it is step 1 to 2, use this as needed low dose ICS formitrol. It is named as AIR. And reliever as SOS. That is the ICS formitrol. The same thing, the same drug can be used as reliever SOS. And in step 3, that is the patient is having, we have discussed here, no, the symptoms of at least most of the days, but the lung function, lung capacity is normal. Then we can go with daily low dose maintenance of ICS formitrol, and we can step up with the medium dose if it is more frequent. And finally, if it is not controlled with all of our steps, that is the medium dose maintenance. If it is not controlled, we can add on LAMA, like tiotropium we can add, glycopyrrolate we can add. But before that, we have to think of other differentials. We can go with biomarkers. We have to rethink and we have to check on the phenotype variant, whether it is a cough variant asthma, whether it is allergic asthma, whether it is non-allergic asthma, whether it is asthma related to obesity. That also we have to assess. And other biologics also we can prefer. And I'm not going to discuss this track 2 because it will be more confusing. So this is the only drug, that is the ICS formitrol, being used as reliever as well as for maintenance. And that is for adults and adolescents more than or equal to 12 years. And just one word about the track 2. Here we are using the ICS SABA or the SABA alone rather than the ICS formitrol. So with an example, we can discuss the same thing because we'll keep in mind all the drugs rather than all these flowcharts, the drugs name, and that will be in our mind and we'll be remembering more with this example. Like in step 1 to 2, take like budesonide formitrol. An example for that, let's say Foracort. But regarding Foracort, it is budesonide will be 200 microgram and formitrol will be 6 microgram. Here it is given as 160. Actually, there is a small difference only. But to know, for your information, budesonide formitrol 160, 4.5, it is actually Symbicort, one brand is there. Symbicort is 160 microgram of budesonide, but again the formitrol there, it is again 6 microgram. Just to make you remember more easily. So if it is step 1 to 2, take one inhalation as needed. That is AIR, anti-inflammatory reliever. If it is step 3, take one inhalation in the morning and evening and one inhalation SOS. If it is step 4, take 2 inhalations morning and evening, 2 puffs morning and evening, and one inhalation SOS. Step 5, we have discussed. And always, if you are using a normal pressurized metered dose inhaler, use a spacer. And regarding the spacer, if it is less than or equal to 4 years, we can use a spacer with mask. If it is more than or equal to 5 years, we can use a direct spacer. And this is the same thing we discussed. Again, they have explained they have tried their best to explain, to make it more simple with multiple flowcharts and multiple tables. the same thing. And coming to pediatrics less than 12 years, that is 6 to 11 years. Here, the patient, the child is coming to you, and here there is no step 1 and 2 has been given separately. We can start from here. Again, the same thing, daily symptoms or waking up at night once a week or more, and there is a low lung function. Actually, this side is almost the same in adults as well as the pediatric. And if it is so, we can go with step 4. Here, there is slight difference in the medication. The medication here, there is, if it is step 4, there is a medium dose ICS LABA plus SOS ICS SABA can be used. I think rather than going in this way, we can start with in this slide because this is more easier, I think. So here the child is coming to you, and in step 1 means there is symptoms of 2 days per week or less than that. Here we can use low dose ICS formitrol or ICS SABA SOS. See, low dose ICS formitrol or low dose ICS SABA as needed we can use. That is in 6 to 11 years. I think that is almost same with the adult patient. Step 2 we can use daily low dose inhaler. So why it is being given as second, that is a separate one, because in adults, we have seen that the step 1 and 2, it is SOS. Step 1 and 2, it is SOS. Only in step 3, it has become marked, that is daily low dose maintenance. But in pediatrics, from 6 to 11 years, it is from the step 2 itself, there is low dose ICS SABA, ICS can be given. Here, another difference is here only ICS is being given. There is no LABA, there is no SABA for daily purpose. And SOS, what we have to use as reliever here, reliever we can use as SABA. Short acting beta agonist we can use as SABA in all these steps. So in step 2, there is a difference. There is low dose inhaled corticosteroid only used daily. And in step 3, we can hike it. Here we can use low dose ICS LABA or a medium dose. This low dose ICS we can increase, we can escalate to medium dose ICS, or we can give a low dose ICS LABA or low dose ICS formitrol as maintenance. So don't confuse with all these things. Just remember any one drug for your practical use or for your exams also. Just remember one drug. Like here we are using low dose ICS. We can increase it into medium dose ICS or a low dose ICS LABA as in adults. If it is again, we are stepping up to step 4 means medium dose ICS LABA. This low dose can be titrated into medium dose ICS LABA, or we can go with expert advice here. And in 5th, again the same thing. LABA we can, along with LABA we can add on LAMA, anti-IgE, anti-interleukin 5, etc. can be used. In all this thing, the reliever is SABA, and we have to remember the steps. So again, the symptoms are all the same, but we have to remember the difference in the medications. That is the personalized treatment for children in 6 to 11 years. The same thing has been given in another form, in another table. So special consideration in pediatrics, PRAM score can be used. Another pediatric assessment score, another score is there that can also be used. Pulse oximeter is mandatory in all children. Target O2 should be more than or equal to 94%. Assess the feeding ability in infants as a severe marker. If the patient is unable to feed, that has to be taken as a symptom, as a severity marker. Drug delivery, use a spacer over nebulizer wherever possible, even though it is having equivalent efficacy. Use face mask with spacer if less than or equal to 4 years. Mouthpiece for more than 4 years. And here we have discussed, we are going to discuss regarding in less than 5-6 years, there won't be any ICS formula. That we'll be going to discuss in next slide. And the caregiver has to be given special education. Assess the response before repeating each dose, because we have to avoid over treatment. Early escalation should be done if worsening. Do not wait. Please transfer the patient urgently. Look for the red flag signs. Look for the severity And if needed, if you are not equipped, if your center is not equipped, please do not wait. Please do not keep the patient waiting. You have to refer and follow within 1 to 3 years. Coming to finally, the last topic about this personalized management asthma is less than 5 years. Actually, less than 5 years is some kind of a dilemma, because from the diagnosis itself, there is no particular blood test, or there is no particular lung function test to assess. We are going clinically. And the criteria, I think there is no time to discuss the criteria. But one thing we have to keep in mind, recurrent or acute wheezing episodes, or at least one acute wheezing episode with asthma-like symptom between episodes. And this is the symptoms. Next is, there is no alternative diagnosis. There is no other diagnosis. And along with that, there is timely clinical response of respiratory symptoms or signs to asthma medication. That is, we are giving the medicine. We are giving a trial of SABA at home or at center, and you are you are observing for improvement. So all these things, 3 things are present, then you can label the child as asthmatic. If it is only 1 or 2 criteria is met, then you should not label the child as asthmatic. You can put as suspected asthma. So again, this chart will be like this. Here, there is, in case of step 1, there is infrequent acute wheezing episodes. So there is no or minimal interval asthma symptoms. That is very infrequent symptoms. Actually, the guideline is saying that there is no sufficient data for daily controller. That we can try giving ICS. Some other articles are showing that we can try giving daily low dose inhaled corticosteroids. Again, here we can notice that there is ICS alone. There is no LABA here, or there is no formoterol here. So daily low dose inhale is being given as should be given in step 2, and step 3 double the low dose ICS. There is no there's no other add-on like LABA here. And step 4, you should refer the patient for expert assessment. So symptoms has been given. When we should be given a step 2. Asthma symptoms are not well controlled with step 1, or there is 1 or more severe exacerbations in past 1 year. There is at least 1 exacerbation. Last year, the child had 1 exacerbation. This year also, the child is having 1. Then you can go with the step 2. You can go with the step 2 management. Then asthma is not controlled on low dose ICS. It is step 3. Double the dose of low dose ICS. And coming to the 4th one, asthma is not at all controlled with step 3 ICS. Even with double of the low dose ICS, the asthma is not being controlled. Then what should be done? You have to refer. Should not wait. You have to refer. So that is about our treatment main the charts, flow charts, and tables. Then few other points like oxygen therapy we have already discussed, like supplemental oxygen only if less than 92. Target the SpO2s to 92, 95. Avoid hyperoxia. If it is mild exacerbation, no need to give O2. If it is moderate, also just assess. Only if the SpO2 is dropping, there is need for O2. Continuous monitoring in severe cases. And in child less than or equal to 5 years, maintain the O2 as more than or equal to 92%. And adjunctives, we have discussed, ipratropium bromide has to be given in moderate to severe exacerbation. And they are stressing that it should not be given at mild exacerbation. There is no need to give in mild exacerbation. IV Mexalf, if you are in an emergency department, or if you are in a tertiary care setting or secondary care setting. If it is anaphylaxis, treat with epinephrine. Treat the anaphylaxis first. Then proper hydration and electrolyte monitoring. Antibiotics has to be given only if there is any infection is suspected. So coming to the another main point, that is systemic corticosteroids and OCS, oral corticosteroid stewardship. That is, early administration reduces the relapse and admission. It is a double-edged sword, the steroids. If it is given at proper time, at proper dose, it is a life-saving drug. But it should not be given at high doses for long duration. If it is not indicated, you should not use. And the dosage will be like adults, it is around 40 to 50 milligram can be given for around 5 days, 5 to 7 days you can give. Pediatrics around 40 milligram you can give the patient to the child. And if you are using for a short duration of child, like for 5 days or 5 to 7 days, there is no need to taper. If you are using more than 7 days, then you have to plan tapering the drug before stopping it abruptly. And do not stop any drug that is long-term steroids abruptly. It can cause many other issues. And you can also give methylprednisolone or dexamethasone, and the doses has to be calculated. And the OCS stewardship have told that track 1 has to be followed to reduce the oral corticosteroid use, and you have to calculate the cumulative oral corticosteroid exposure. Like if the patient is telling that last 3 months back I've had the same attack, every 3 monthly I'm having the same, I had to take the oral corticosteroids, then it becomes a poor prognostic factor, it becomes a severe asthma and controlled asthma. Then you have to check that the other issues, like you have to look on the adherence of the medications, you have to look on the compliance of the drug, etc. And here also stepping down options. Stepping down is another big topic. And at least keep in mind that if the patient is stable for at least 3 months, then you can plan for stepping down. So at least 3 months, you have to ask the patient to maintain that same track to the same step before stopping the drug by his own. And few points about the biomarkers, the type 2 biomarkers. The commonly done tests are blood eosinophil count and FeNO, that is fractional exhaled nitric oxide. Another two tests are serum total IgE and sputum eosinophils. There are multiple indications, multiple uses of these points. A few points about that. It is helpful in diagnosis of asthma. Like if the patient is, if your facility, if your hospital is not equipped with the spirometry or PEF, and if it is negative, then you can go with FeNO or BEC. And if it is high, then it is supportive of asthma. You can take it into consideration. And for the phenotyping of asthma, like high blood eosinophil count or high FeNO, suggestive of allergic asthma, like that you can classify based on the biomarkers. And also for the prognosis and risk of exacerbations, like high blood eosinophils count means, and if there is high fractional exhaled nitric oxide, high FeNO means there will be good effectiveness of inhaled corticosteroids. There is a good role of inhaled corticosteroids. Another thing, even with the good amount of good dosage of this medication, if the patient's eosinophil count or FeNO is high, then that is a poor prognostic factor. Like that, you can make it use in classifying and also the risk of exacerbation you can calculate, and also selecting the treatment and predicting response. We can use these biomarkers. And few points on add-on biologic therapy, that is anti-IgE omalizumab. A new drug has been introduced, like interleukin 5 depemokimab and anti-interleukin 5 or alpha mepolizumab and dupilumab. All these drugs actually has been used by the specialist experts before we can counsel the patient on these drugs, these possibilities. Like we should not say to the patient like there is no other drug. I have tried all my best. There is no other drug. Like that, we should not make the patient hopeless. We can discuss on the possibilities. Like there are many drugs. There are many injections to suppress, to control your drugs. So that for that, I can refer you to the expert. So few points on clinical phenotypes. There is allergic asthma, and where there is sputum eosinophils will be high. There is non-allergic asthma. There will be cough variant asthma or cough predominant asthma. There is adult onset asthma, that is late onset asthma. Asthma with persistent airflow limitation. That will be a less reversible. Asthma with obesity. In adult onset asthma, always rule out an occupational asthma. And how will you prevent the future exacerbation? The adherence to the ICS therapy, correct inhaler technique, vaccinations, smoking cessation and pollution avoidance, asthma action plan, regular follow-up and control assessment. Vaccinations is another part to be stressed. And here we can advise the patient on flu vaccinations annually for adults. If it is for children, we can have to give a booster after 1 month. We can give RSV, but not available in India right now, I think. And COVID vaccination also has been proved to reduce the exacerbation of asthma. If it is an adult more than 50 years, we can ask the patient to take pneumococcal vaccine. Now we have introduced PCV20 as a single dose vaccine. So all these vaccines have been proved to reduce the exacerbations of asthma and to prevent further complications of asthma, and that we can stress the patient to take. And finally, about few points about the correct inhaler technique. This is the spacer for children more than or equal to 5 years. For less than or equal to 4 years, we can give that with the mask. So regarding adults, first of all, have asked the patient to shake the inhaler properly and put in this spacer. One end should be kept with that is with the inhaler, and another end the mouthpiece. And before pressing the medicine, breathe out fully, completely exhale, and exhale away from the inhaler and do not breathe into the inhaler. Position and seal the lips. Here we have the mouthpiece, we have to seal the lips and press once and inhale slowly. So how how the patient should inhale at least slow, deep breaths of 3 to 5 seconds has to be done. And if the patient is having difficulty, then ask the patient to breathe, to keep it at least for 30 to 60 seconds. That is half to 1 minute we can ask the patient. And another important thing that you have to stress is that the inhaler should not be removed from the other end. Usually the patient will be removing the inhaler from the other end. All the medicines will be going out. So that has to be kept. And hold the breath for 10 seconds and breathe out slowly through nose. Do not ask the patient to breathe out through the mouth. The mouth has to be sealed with the mouthpiece. Breathing out should be through the nose. And you have to wait between the two puffs. Ask the patient to wait. That is, at least a 1 minute should be given. 30 to 60 seconds, or at least 1 minute, we can ask the patient to wait before the second puff. And actually, the guideline is saying that before the second puff, the inhaler should be shaken. That can be advised, but I don't think so. The patient will be following that, because too much of instructions will make the patient more avert. That is, they won't prefer this thing. And after the inhaler, ask the patient to rinse the mouth and do not drink the medicine. Do not drink the water. Ask him to spit it out. Do not swallow. So it applies to steroids only. No, there is no need for any other LABA medications. Coming to the child, again the same thing. But in child, we are using a mask, no? So the same thing. The mask should not be removed away from the child's face. It should be kept closer to it. And from the other end, the medicine also, the inhaler should also be kept. And here the child cannot hold the breath. So we can ask the child to take 5 to 6 tidal breaths and watch the valve flicker during each breath. And 10 seconds per puff can be advised. And here also, before another puff, it is ideal to wait for at least 30 to 60 seconds. And once the child is able to cooperate with the medication, with the spacer, we can switch to the mouthpiece and ask the child to breathe slowly, not forcefully. Okay, the same thing applies here. So rinse the mouth after ICS through and clean the spacer every week. Actually, some guidelines says that the spacer should not be cleansed with the soap, but some guidelines are saying that you can use mild soap to clean it. But one thing is common is that you should not use any scrubber. You should not use any other antiseptics or any sanitizers, and we should not avoid rubbing the surface. Allow it to drip and dry, and replace the spacer every 6 to 12 months. Every 6 to 12 months, ask the patient to replace. So some of the non-pharmacological interventions, that is stress on smoking cessation, very important. And environmental tobacco exposure and vaping has to be stopped. Regular physical activity has proven benefit in reducing the exacerbations. And advice about the prevention of exercise-induced bronchoconstriction use. That is, usually they will tell that my child is a footballer, he used to play, but as the asthma started, he is not able to play now. He's having regular attacks. So he is sitting idle at home. And later he develops obesity. But you should not tell that. That you should counsel the patient, counsel the child. There is no contraindication for any avoidance of physical activity. The child should play. The adult should have a physical exercise. But before the exercise, if there is an evidence of exercise-induced bronchoconstriction, then you can use SABA before exercise. You can use ICS formitrol before exercise or during the exercise, during the play. If there is an episode, ask the patient to use inhaler in between that. And another advice can be given as warm up before exercise. That also can help reduce the inflammatory response. And we can also engage the patient into pulmonary rehab programs and avoidance of occupational or domestic exposure to allergens or irritants. Like patients will be having the many other financial issues. They are forced to work in smoky, polluted areas, in polluted industrial areas. There won't be any other options. So we have to keep in between. Like we should not be that much strict with our protocols. We have to be in their patient's position and also think on other remedies like using a mask during their occupation during their job time, like that. Or if it is possible, you can ask the patient to change the nature of the occupation, nature of the job, and avoidance of medications that may worsen asthma, like beta blockers. Even the ophthalmic, that is ocular use drops, can also can trigger. And healthy diet is very important. Avoidance of indoor and outdoor allergens, weight reduction, breathing exercise also have found very important, very effective, like pranayama in yoga. Everything is useful. And avoidance of indoor and outdoor pollution and dealing with emotional stress. Many patients, especially females, they can have this asthma attacks during their emotional stress, during exams, during any interviews and all, during any long journey and travel, during any other family issues. All these asthma attacks can occur. So that has to be dealt with. And indication for referral for expert advice. Like if you are having difficulty in confirming the diagnosis of asthma, if you are suspecting any occupational asthma, if there is persistent or severely uncontrolled asthma or frequent exacerbation, the asthma is not under your control. You have tried your best, still the asthma is ongoing. Then you have to refer the patient. There is near fatal or asthma or suspected or confirmed anaphylaxis, or there is a food allergy in the patient with asthma, you can refer. If there is a need for long-term OCS, then think about the significant side effects, think about the risk of side effects, and finally, suggesting the complications. If you're suspecting the complications or subtypes of asthma, you can refer. And the last slide, red flags. Onset of asthma after 40 years, you have to think of some other DDs like COPD, heart failure, bronchiectasis, pulmonary TB, interstitial lung disease, pneumoconiosis. Poor bronchodilator response, hemoptysis, weight loss with the symptoms, clubbing, stridor, localized wheeze, recurrent pneumonia history, chronic productive cough, cardiac symptoms. If at all any of these are present, then suspect alternate diagnosis. The red flag signs has to be kept in mind and look for other causes like foreign body, especially in children, COPD, heart failure, pneumonia, bronchiectasis, pulmonary TB, interstitial lung disease, pneumoconiosis, and many other things are there. So this is what we have discussed, the same key home messages. Assess the severity early using systematic criteria, and SABA with spacer has to be used in different ages that we have discussed and acute asthma presentations. Give only oxygen whenever needed, like less than 92%. Track one is usually preferred, and always keep in mind of unnecessary use of oral corticosteroids or IV corticosteroids. Discharge planning criteria has to be kept in mind. Ask for arrange proper follow-up. Give a written action plan. Children, you can use a PRAM scoring or PAS scoring. And prevention, that is vaccination, proper awareness of medications, inhaler techniques. Everything has to be given, and also treating other comorbidities like obesity and other drugs. Thank you.
Thank you, Jayaganesh. It was a wonderful presentation. I think you dissected the GINA guidelines so well, and you have given a practical approach to everybody. I request all of you to go through the GINA guidelines and apply it depending on your scope of practice. So what type of patients you see is very important. If you're not happy with small children, better don't see, because, there's a slight difference in treatment, right? If you see a child less than 5 years, they do not use LABA. So there are some mild changes, and even if a small thing is very important, because any drug which is not given in the guidelines, if you start giving, and it's a legal problem, right? So you should be very careful. And they have not specified much about epinephrine. Epinephrine they've told only in anaphylaxis, but there is, I think for the past many years, I have been giving nebulized epinephrine for severe persistent asthma. That is what it is with silent chest and all. I don't know what is your take about it. We give a racemic mixture. Usually you give it for stridor. And yeah, I think in adults, you should be really worried, because if they have underlying cardiac problem, you should not give, because it will increase the heart rate. Otherwise, in young people, epinephrine and resistant asthma usually shows a very good. I think we have nothing else to give. Even if you have given magnesium, still patient is not responding. My personal experience with epinephrine was good. I don't know what is your take.
I have to go through the guidelines
Yeah,
once.
you have to go through the guidelines. Is not good. AHA guidelines also, it's given only for stridor. Previously, it was given for asthma. You give subcutaneous IM epinephrine and all for asthma, severe exacerbations. It's not responding to steroids, not responding to magnesium, not responding to ipratropium, then what else to do? It's quite difficult phase. Now the most trigger factors come as H1N1. Many asthmas have triggered due to H1N1. Many land up in ICUs. And also another thing is aspergillosis, which trigger asthma and they come to ICU with. So that you should be very careful. You should not miss that. So open to questions.
Ma'am, the doses of low and medium dose ICS formitrol, are they same? Doses of ICS formitrol, are the doses same for children and adults?
Yeah, that's all. Slightly different. Yeah, less
than yes, 5. Actually, yes, ma'am.
In adult, it's 160 bar 6.50.
Yes, ma'am. Actually, in another part of the guideline, it is being given as a different thing. That I will just.
Adult, it is 160 bar 4.5.
But actually, ma'am, I have just gone through that, and in that, if you are using in adults, ma'am, is the screen visible?
Yeah.
Adults and adolescents, if it is a budesonide for low dose, it is 200 to 400 microgram.
Yeah.
And if it is medium dose, around 400 to 800. For high dose, it is more than 800.
Okay, this is for the usual treatment, right?
Yes, ma'am, usual treatment.
Yeah, not an exacerbation. Okay.
No, ma'am. Okay. Fluticasone, it is 100 to 250, 250 to 500, and high dose is more than 500. If it is beclomethasone, it is 200 to 500, 500 to 1000, and more than 1000 in high. But coming to the children, it is budesonide and beclomethasone have been given as same dose, and it is 100 to 200 in low dose, medium it is 200 to 400, high it is more than 400, and fluticasone 50 to 100, 100 to 200 as medium, more than 200. And in all this formitrol is having the same dose.
Same dose.
In our preparations, it is as 6 microgram it is being given.
Formitrol is the same dose. Yeah. Steroid,
yes, ma'am. No, steroid, I think I've already put on that slide.
I think the steroid which is available commonly is fluticasone and budesonide, right?
Yes, ma'am.
Beclomethasone.
Beclomethasone is not that much easily available. Actually, this is a common preparation on the Foracort used to give.
Yeah.
And 200, we can give low doses 1 puff BD.
It comes as Seroflow, right?
Sorry, sorry, ma'am, fluticasone instead of budesonide and formoterol.
Yeah.
Budesonide, formoterol, Foracort, fluticasone as Seroflow, like that it is coming. So it is one puff. We give one puff is low dose, 200 mg BD. Two puffs, if we are giving, it becomes 400. Two puffs BD. Like that, the dosage goes on.
No more questions? Any more questions? Vishnu is there?
Ma'am, I'm here.
Yeah.
I'll share the PPT. Someone is asking about
Yes,
it.
sir. You can get the PPT. It's all given the GINA guidelines. You go to 2026 GINA slide set, you can get around 110 slides or something like that. But Jayaganesh has done a good job dissecting these guidelines and explaining to you.
Thank you. Ma'am,
Yeah.
one question for you on chat box. Any patient when we are starting inhalers all ask the same doubt. Will inhalers will become an addiction? From your experience, ma'am, how will you tell me?
What addiction?
Whether inhalers becomes addict once you start on the medications, whether you have to take it lifelong.
Asthma is not curable, right? You can only control asthma.
And
Right?
they are ready to take on lifelong homeo medication.
Yeah, that's what.
other medications, many other
Asthma
therapies.
cannot be cured. It's just you can control your asthma. So you need to depend on that. But as they told, no, as reliever therapy, you can take it intermittently as needed, and depends upon the type of asthma, right? If it's a mild asthma, moderate and severe asthma, depends on that. You can. If it's a moderate asthma, you need to be on ICS, right? Definitely. Only anti-inflammatory therapy will improve that. So don't worry about addiction. Only thing, use it in the right way.
Ma'am, there's another question regarding magnesium in asthma, ma'am.
What is the question?
Magnesium in asthma.
Yeah. Magnesium,
Treatment.
what they have told us, the dosage is around, you give it as an infusion, right? Over 20 minutes.
Yes, ma'am.
Over 20 minutes. For child, any different dose? I don't know. I have to go through.
Ma'am, I'm not sure. The new guidelines have been changed.
It is available as 1 gram ampule, right? You give it in 100 ml over 20 minutes. So it's a good bronchodilator. It can be given thrice daily, but only thing, you need to check your serum magnesium level also. The highest level is 2.5 or something. It should not go beyond that. And it can be used as a nebulization also, but it is not given in the guidelines. But in some books advise magnesium nebulization also, 1 gram 8th hourly. There's not much of side effect because magnesium you give in eclampsia very high doses, right? The only problem is muscle weakness, respiratory muscle weakness. So for that you should be little worried about. Then you give it in COPD, but for asthma, you can give it as an infusion and also nebulization. And according to guidelines, infusion can be given. But for how many days, ethanol has not been specified. Only in the time of acute asthma exacerbation, you can give a single dose of 2 grams in 100 ml NS over 20 minutes. Give some relief. Anything else?
No, ma'am, I think the doubts are that is clear. No more. No more doubts. Magnesium tablet available. Magnesium tablets.
Magnesium tab is available, but it's not given for asthma, not approved for asthma. It is approved only for hypomagnesemia.
Nowadays for sleep and for good sleep.
Yeah, so many other, for muscle cramps, for diabetic neurogenic pains and all, they give magnesium also, but not for asthma. As of now, magnesium IV is only approved, even nebulization is not approved. But still we give because we have no other options at times.
Okay, ma'am, I think we can wind up already. Going to be 9:30.
Aishwarya is there?
Yes, ma'am. Yes, ma'am. I think we can wind up the session. So let me, on behalf of AFPI Kerala chapter and Spice Road Kerala chapter, I would like to extend my special appreciation and thanks to Dr. Jayaganesh for the extensive coverage of this exhaustive topic. You have simplified all the concepts and done justice to this session with your wonderful presentation, Jayaganesh. I'm sure everyone has benefited from your session. Thank you. And also, I would like to extend my thanks to Dr. Indhu Rajeev, Madam, for moderating the session and for sharing her valuable inputs. Madam is an expert in this topic. Thank you so much, ma'am, for your time.
Thank you.
And my thank you, ma'am. And my special thanks to the National Spice Route team under the leadership of Dr. Vishnu BS and the Spice Route Kerala team led by Dr. Sujitra for all the support. And special thanks to everyone for attending this session. Thank you so much.
Thank you, AFPI. Thank you, Indhu ma'am. It's been a privilege sitting in front of you from being a student the past 6 months before, now as a junior doctor. It's my privilege.
Not a junior doctor. You're not a junior doctor now.
No, in front of your experience, I'm
At least a senior resident, right?
yes, ma'am.
Then junior consultant.
Yes, ma'am.
Nice. Anyhow, nice. You have taken so much of pains. Because I had a lot of headache reading this for the past 3 days. I couldn't even see that it's written so small. I had to enlarge it in the mobile and start reading it. But it's very nice, actually. I think it's very useful. And only thing is, they keep on changing every year. Every year, JINA guidelines come, there is a small. So we need to update it every year. If you take the last years, there are a lot of differences. So I think you have done a very good job. And my best wishes to you. And thank you so much.
Thank you all.
Thank you.